Good afternoon. I'm Chris O'Connor, president of the Nova Shore Heart and Vascular and adjunct professor of medicine at Duke University. And I'm pleased to be with you remotely today to discuss something I'm very passionate about, and that is how negative trials in acute heart failure have improved patient outcomes. I'm sorry I couldn't be with you live. I was really looking forward to sharing time with you and my good colleague, Dr. Joe Rogers, but I had a death in the family. But let me take you on a journey through my career, which is focused on acute heart failure, and share with you lessons learned from these trials, most of them negative trials. And yet, by learning from negative results, we can actually redirect the science, redirect the course that we're taking to achieve improved outcomes. Just a little bit about my background. Uh, my mom, who just recently passed, uh, came over from Germany. And interestingly, she was the governess for Dr. Stanley Sarnoff, who was the director of the NHLBI when she came over to the United States. Um, she lived a healthy life up until 93 and just passed a couple weeks ago. My dad grew up in D.C., served in the Korean War in journalism, and died at a young age from cardioembolic stroke at age 56. So a lot of influences, perhaps, on going into cardiology, and also the balance between the quantitative side from my mom and the writing side from my dad. I would be remiss if I didn't remember my terrific mentors at Duke, my dear former chairman of medicine, who is passed, also Dr. Joe Greenfield, who really had the trust in me to pursue a career in heart failure, and Dr. Rob Califf, who I was his first fellow, who pushed me to think about quantitative medicine in the field of acute heart failure. Well, if we look back to some of the early influences in this field, Dr. Eugene Stead, who was the chair of medicine at Duke for many years, was really the first heart failure doctor at Duke. And in this publication in 1940, the effects of application of tourniquets in the hemodynamics of circulation, in which they placed PAC catheters in, and looked at how the hemodynamics changed and how symptoms changed. They demonstrated significant improved dyspnea reduction wedge, but a transient rebound. And what I would have to say is that this study probably forecasted much of the results of acute IV therapy, pharmacologic therapy, and acute decompensated heart failure when it was administered short term. That is, we saw very early on strong effects, but these appeared to be transient and thus resulting in neutral results. And I'll share that journey with you over the next several examples. Well, we're interested in this area of acute decompensated heart failure because there still remains a high mortality and hospital readmission rate. And as health system leaders like Dr. Rogers and myself, there's considerable penalties still that are being put forth to hospitals and health systems for excessive heart failure readmission rates. And as you can see here, while we believe that we've bent the curve in the outpatient setting, much of the residual risk of patients once they've been hospitalized is still high. And so when we think about the goals of therapy, obviously making people feel better, remain out of the hospital, slow the progression, and live longer while limiting adverse events are admirable goals for the patients that we serve. Well, one of the first studies that looked at intravenous therapy in acute heart failure, um, to no surprise, was called the first study. And I had the privilege of being a fellow working on this study. This was the use of Flolan, or intravenous prostacyclin, which had been shown to be very effective in pulmonary hypertension. And so there was a natural interest from the sponsors and the academic community to move this into advanced acute heart failure. And this trial was done looking at very low EF, less than 25, randomized trial. And in the right panel, you can see the trial was stopped early by the Data Safety Monitoring Board because there was no benefit in a trend towards increased mortality in the epoprostenol group. And when you looked at some of the characteristics that were found in this study, it turned out that there was a lot of dobutamine use, and maybe even more in the epoprostenol group, maybe because of hypotension. And it turned out that dobutamine was driving a lot of the excess mortality in this clinical trial that we published from this database. So interesting findings here. Inotropes harmful, perhaps. One of the first signals. IV vasodilator, perhaps not beneficial, but more to come on that story. Well, we thought that given that inotropes had such favorable findings on hemodynamics, that could we continue to look at these therapies for benefit in acute heart failure. And the Optime trial was really one of the first large randomized trials, about 1,000 patients, that looked at intravenous milrinone in acute exacerbation of chronic heart failure. Randomized trial. Our thought was that milrinone, by augmenting the hemodynamics, would allow us to get patients on better drug therapy at the time of discharge. But lo and behold, what we found is that there was a six-fold increase in adverse events, that there was excessive hypotension, and while rehospitalization was not different, there was about nearly a 20% increase in mortality over the 60-day period. So this was a disappointment, and we again learned that the inotropes were certainly not doing what we thought they would do. We were able to, in one of my first journal efforts, and with Joe as my senior associate editor, along with Joanne Lindenfeld, we were able to create a column in the journal that resurrected clinical trials that had been negative or neutral and never published. And this was one that we resurrected, which was the levosimendan REVIVE study, and a very interesting study in which, again, another inodilator approved in many countries in Europe showed a favorable effect on short-term outcomes of feeling better, but the actual hard outcomes were increased. Adverse events were increased, such as ventricular tachyarrhythmias and mortality. And so, again, a drug that didn't that had great promise but didn't pan out in the randomized controlled clinical trial. Well, given all these starts and stops, inotropes not doing well in 3 examples, vasodilators didn't look promising initially. We said, well, maybe we need to take a step back and see if the hemodynamic hypothesis was correct. And so we put forth, under the leadership of Rob Califf and Lynn Stevenson, Monica Shaw and myself, a proposal to the NIH, which was funded and entitled the ESCAPE trial. This was a landmark trial because it was really a first strategy trial in acute heart failure, in which 400 patients were randomized to assigned to a PAC catheter and then guided therapy versus usual care. And what we found in this study was indeed one could optimize hemodynamics quite well with the PAC catheter. As you can see, at 72 hours, the right atrial pressure dropped 40%, wedge was down 40%, index up significantly, and SVR down another 40%. So lots of improvement in hemodynamics, and to correlate with those, we had early use of brain natriuretic peptide measurements. You can see a 30% reduction in the PAC catheter arm, but also, interestingly, and this was baseline to discharge, a 30% reduction in the usual care clinical management non-invasive arm. And that may have been the first hint that while we were able to get this dramatic improvement of 72 hours in hemodynamics, by time of discharge, there perhaps was a rebound and both arms were equivalent. And lo and behold, that's what we found. We used a novel endpoint of number of days alive out of the hospital, and over the 6-month period, there was absolute identical proportion of patients with this endpoint in the PAC catheter arm and clinical care arm. And so you say, why? Well, was this a tourniquet effect? We used vasodilators, we used some inotropes in that first 72 hours, but they all had to be turned off. And did that all come back and equilibrate equally with the clinical care arm? And also, the PAC catheter was at that time associated with some significant adverse events, as you can see on the bottom right panel. And that probably contributed also to neutralizing any potential gain. Well, databases are rich with information, even if you have negative or neutral trials. And Dr. Rogers and I continued to interrogate this database for many years after the completion of the trial. And one of the rewarding examples of this was the development of the escape discharge score, a score that you can see here was based on some very simple parameters to predict mortality at 6 months at time of discharge. And interestingly, this is predictive analytics. This is an early form of artificial intelligence, machine learning, and this was incorporated into the guidelines and actually used in subsequent clinical trials as an inclusion criteria to enrich the event rate of those trials. But this was the PAC catheter trial escape resulted in a large reduction and the routine use of PAC catheters in the management of acute decompensated heart failure. And we also saw, based on this analysis from the escape data, that the inotropes were associated with a increased mortality, and that vasodilators seemed to perform better than inotropes. And certainly, when you use both of these, there was a high residual mortality. And so, I think we also learned that perhaps the inotrope routine use also needed to be attenuated, and we saw this in clinical practice from our registries, a significant reduction in the routine use of dobutamine and milrinone in clinical practice for acute decompensated heart failure, and a leaning more towards vasodilators. Well, we're kind of stuck here. We still had this very symptomatic population coming into the hospital, and what were our therapies? Well, Niseratide had emerged onto the market. It had been shown in some small studies, VMAC and others, to improve dyspnea, reduce wedge pressure. But based on what we had learned to date, we were uncertain of the clinical outcomes in the routine use of Niseratide. And this therapy was adopted broadly in the United States in this patient population. Well, we got to a point where the we convinced, with the help of Dr. Braunwald, the company at that time, J&J, to say, listen, you better do an outcome study. Otherwise, people are going to, not take this therapy wisely, because some new meta-analyses had come out showing some harm on mortality and renal function. So the ASCEND-HF trial was designed, and this was the largest clinical trial in acute decompensated heart failure conducted to date at that time, an international effort to really put to rest whether nasiratide versus placebo improved outcomes, looking at both dyspnea and 30-day death or heart failure rehospitalization. And what we found is that there was a small improvement in dyspnea with nasiratide at 6 and 24 hours. But the clinical, if you see the numbers there, the clinically meaningful difference was felt not to be accepted. In fact, we had asymmetrically split the alpha in this trial so that significance was 0.001. So even the 24-hour difference with that strong p-value was not technically statistically significant. But more importantly, if you look at the right panel, we did not show an improvement in death or rehospitalization for heart failure. And I think this really put the definitive, with 9,600 patients, a definitive results on nasiratide. And this negative or neutral trial took essentially over a year period, took nasiratide utilization down to near zero. Again, perhaps helping patients from an unnecessary therapy. We were still trying to find a therapy that might be used short-term to help patients. And so ularitide was more of a designer gene type natriuretic peptide therapeutic, may have had more favorable effects on renal function. Randomized trial of over 2,000 patients, lots of events, and again, no difference in mortality, as you can see here, between drug and placebo. Interesting caveat from this trial, and when you do international trials, you have to be careful of the quality of the data across many regions. And what was learned post hoc, which doesn't change the results, that 358% of the patients were not eligible. This was really mostly from one country in the world. When those patients were removed and you used only those who met the inclusion-exclusion criteria, ularitide was superior to placebo with a nominal p-value, which really is a sad story, but tells us how important quality oversight of clinical trials must be maintained. Well, we continued our efforts to think about designer vasodilators and relaxin, a naturally occurring insulin-like protein peptide, a normal hormone of pregnancy, was associated with significant hemodynamic beneficial effects on direct hemodynamics and on other aspects such as renal blood flow and renal function. And so in small trials, this looked favorable. In a large phase 2 study of 1,100 patients, placebo versus serelaxin, the relaxin peptide showed a significant improvement in dyspnea at 5 days. And also it showed favorable improvement in biomarkers, both in the attenuation of the release of troponin, a more rapid reduction in NT-proBNP, and an attenuated rise in cystatin C. All of these look very favorable, and the clinical outcomes were favorable. As you see on the top panel of this slide, death CV death through 180 days and all-cause death through 180 days was significantly reduced by about 37%. And this data with 1,000 patients, people said, well, why don't we, and this was the second trial, why don't we go to the Cardiorenal Advisory Committee for approval? And it did, and because of the small number of events, as you can see, about 90 deaths, 100 deaths, the Cardiorenal Advisory Committee said, no, let's do one more trial. And the bottom panel summarizes that next trial. A 6,500 patient trial randomizing placebo to serelaxin with a primary endpoint of mortality and their CV mortality, and there was absolutely no difference in mortality in the treated group versus placebo group, which put an end to the development of this therapy. And so we continue to pivot and think about other ways to improve outcomes. We had seen through the escape data the importance of renal function. And so this interesting drug, ralophilin, which is like theophylline and adenosine A1 receptor antagonist in acute heart failure, showed favorable effects in phase 2 on renal function. Phase 3 study in a 2-to-1 randomization of 2,000 patients. No difference in percent of patients receiving treatment success, which was a trichotomized endpoint that looked at freedom from death or worsening heart failure and renal dysfunction. And then when we looked at those endpoints, death, CV, hospitalization or renal rehospitalization at day 60, again, no difference between drug and placebo. So as you can imagine, very depressing course of 10 years of work for myself and Joe Rogers and others in this field. People said, well, I was going up for tenure at that point. They said, you've done a lot of good work, but they're all negative trials. And this was part of the messaging I got about when I went to the tenure committee. You've shown us a lot of negative things, but nothing that's helped patients. Well, I'd argue a lot of these studies did help us redirect the science. And Caliph was an adamant critique of my work. Why can't you conduct a positive study? Well, what are the lessons that we learned from these early experiences? You need large sample size in order to be certain about clinical events. And those sample sizes need to be, well in the thousands. If it's a very high risk population like escape, it could be low as 400. But acute hemodynamics, not a reliable target. Acute short-term therapy is mostly a pharmacological tourniquet. Less congestion was associated with better outcomes. And hundreds of thousands of lives and healthcare dollars were saved and patients improved by reduced use of inotropes, less routine PAC catheters, less fancy vasodilators, less ultrafiltration, better diuretic dosing, palliative care, more exercise, redirecting the clinical science, the benefit of clinical trials. And here's where we show some of the positives. We took another step back and worked with the NIH on a series of network trials. And with my colleague, Mike Felker, and others, we designed the dose trial, which is a 2x2 factorial design looking at 2.5, the oral dose, Q12, versus 1x, the oral dose, and then factorial design, IV infusion versus bolus. And this was basically a phase 2 study looking at a primary endpoint of patient global assessment. How well is the patient doing? But a host of secondary endpoints. And it's a great example of a neutral trial. We did not meet the primary endpoint on the visual analog scale of patient global assessment, p-value of 0.06, in favor of the high dose diuretics. There was no difference between bolus and IV drip. But if you look at the secondary endpoints, all of them were favoring the high dose. Dyspnea, which is the endpoint I wanted to have at 72 hours, but was overruled by my good friend, Dr. Felker. Um, Freedom from congestion in 72 hours at almost a 40% reduction, change in weight, 2.5 pounds, net volume loss, change in natriuretic peptide levels, almost a 50% reduction. Now, there was an increase in creatinine, but this was transient. But again, as health system leaders like Dr. Rogers and myself, look at the length of stay, an entire day removed with high dose. And so this negative or neutral trial had a lot of positive pearls in it, and as subsequently got into the guidelines as an important contribution of how we use diuretics. Well, we've written on this topic, why negative trials are positive for heart failure patients. But, this is part of the problem. We often have uh, um, got ourselves into a position of believing that these larger numbers, but with few events, could be sufficient for evidence. And here's 3 examples of how that goes wrong. Elite 1, this was losartan uh, in elderly heart failure patients, Visnerenone, another inotrope in heart failure patients, and then Praise 1, 2, calcium channel blocker. The first trials of these, which were thought to be definitive trials, all had events ranging from 45 to 100. And you see the sample sizes there, 400 to 700. Each one of those showed over a 45% reduction in the mortality. And yet, when it didn't convince cardiorenal, which I have to say has been just a gem for us in the regulatory science area because of their discipline on evidence generation. And so these larger trials were conducted, and each one with 500 events showed the exact opposite in the reduction in mortality, minus 14, minus 21, minus 10, meaning um, these went in the opposite direction and nowhere near showed those large benefits that we had seen. So sample size is important. And when you look at sample sizes and you're talking about mortality, you really need to be in the 350 or greater. If you're looking at a New England Journal paper and you want to be secure about the findings, look at the number of events. And if you have the number of events that's in the 300, 350 or greater, you're going to be in a probably adequate range, but lower numbers are going to put you in a gray zone, and certainly under 100 is going to be, and 0 to 50, you'll be utterly inadequate. So where do we go from here? What do we say we have to do to get this right? Well, we had to focus more on strategy trials, registry trials, simple trials, meaningful endpoints. I think we integrated into our thinking, and then targeting populations. Could every patient be expected to respond the same? And I think personalizing the approach was important. Well, as you know, we in the outpatient setting, we had shown that exercise training improved exercise performance, quality life, and reduced heart failure hospitalizations with the HF Action study. And so we took this into the inpatient setting under the leadership of Delane Kitzman and Dave Whalen in the Rehab HF. We did a phase 2 study looking at 360 patients and looking at their ability to improve physical function and quality life. And lo and behold, we were able to show this and in this population, looking at physical function using the SPPB score, and which was highly statistically significant, which has now led to an outcome study that's ongoing that'll be just short of 1,000 patients looking at CV death and heart failure hospitalizations. And that's about a third of the way recruited. So exciting to see that strategy trials, not necessarily pharmacologic interventions, can be beneficial. Uh, Dr. Rogers led a very important study, the definitive study of palliative care in very advanced heart failure. This is a trial that used the ESCAPE um, model for inclusion criteria to get a very high risk patient population. And what he demonstrated nicely is that the multifaceted intervention of palliative care showed a significant improvement in patient reported outcomes. Both the FACET, which is a palliative care instrument, and then the KCCQ, which we're all familiar with, showing almost a 10-point advantage there. And with no difference in mortality at 6 months. So a very favorable finding for patients at the end of life in a randomized trial. Again, a nice example of a strategy trial. An example of a registry trial was based on some database analyses that were conducted by my colleague, Dr. Mentz and Dr. Velasquez, showing that torsemide might have an advantage over furosemide in acute decompensated heart failure with respect to better decongestive properties and a signal on better survival. This was conducted in an NIH trial, really important trial because of the way it was conducted and the cost, 2,800 patients. EHR data was used to populate the database. Statistical monitoring was used to reduce costs and investigator reported outcomes. And so, and using centralized call center to identify patient status. And so this trial, as you know, showed that there was no difference between furosemide and torsemide, even though meta-analyses had shown the opposite. And that's why you have to do randomized trials. And again, a nice model of how we can move the field forward. Many of the sites were able to randomize 6 to 10 patients per month, which is about tenfold more than your typical drug trial that's done today. We saw an advantage of acetazolamide in augmenting decongestive strategies in patients with acute decompensated heart failure. I think this is a really exciting area to look at different modalities of diuresis, building on the dose data. But again, the continuation of strategy. Mike Felker and I led this guided study on nearly 1,000 patients. Could the initiation of aggressive guideline-directed medical therapy at time of discharge by suppressing the natriuretic peptide levels, could that lead to better outcomes? We couldn't show it. And part of that was some inertia in the intervention group to really maximize GDMT. And part of it was the usual care arm probably also did a pretty good job of moving the needle on GDMT. And this was consistent with a quality improvement intervention that Adam DeVore led, in which disease management instructions and education and phone calls were part of an intervention at discharge for acute decompensated heart failure patients versus usual care, and showed absolutely no difference on clinical outcomes, and really could not show significant movement in guideline-directed medical therapy, as you see in the lower panel. Some movement in disease management, but overall, again, a lot of inertia in these types of interventions. Well, people continue to make progress, though, in this space of how can we get strategies to help us with GDMT. And the PROMPT HF trial was an important advance in this area. in which looking at um, best practice alerts being provided to providers versus no alert in the outpatient treatment of heart failure, reduced ejection fraction. And the team at Yale was able to demonstrate a significant improvement in all GDMT. And so largely driven by all classes, but predominantly beta blocker improvement. So a good advance here that one of the first trials that show BPA, which we all are overwhelmed with in EPIC, showing improved outcomes. We continue to think about drug therapy, but maybe drug therapy not as a short-term infusion, but as a drug therapy that was initiated and continued post-discharge. And Victoria, perhaps one of the first to show a positive signal there. That the short-term infusion strategy was not right, but we had to continue the therapy. And here we showed with vericiguat and about 5,000 patients, an improvement, a reduction in heart failure hospitalization events, no reduction in mortality. But interestingly, when you think about a personalized approach in a pre-specified analysis based on quartiles of natriuretic peptide level, a large benefit of the composite primary endpoint and CV death hazard ratio 25%, 25% reduction in those who had natriuretic peptide levels at baseline less than 4,000. So I think a nice beginning of personalized medicine using the natriuretic peptide. Another example of personalizing the approach, the cardiac myosin activator, omecamtiv mecarbil, in the Galactic HF study, 8,000 patients showed a 8% reduction in the primary endpoint. This went to cardiorenal and was rejected because of the modest effect, all driven by heart failure hospitalizations, and also some concerns about how to dose this drug safely, and asked for a second trial. But when you really looked at this data, there was a dramatic improvement in the primary endpoint in those who had the lowest quartile or even lowest median split of ejection fraction. So we hope that future trials will be done with this drug. I think it would be an add to the field, but targeting the very low EF population. And to continue that theme of pre-discharge initiation, I'll just share with you a series quickly of trials that were done. We were involved in this very early on with carvedilol. Was forbidden to use at pre-discharge. We randomized pre-discharge and showed that there was excellent tolerability. And lo and behold, more patients at 60 days were on the drug by the time they got to versus usual care by the time they got to 60 days, which we believe and trended towards improved outcomes. Pioneer did the same thing with ARNI, showing reduction in natriuretic peptides, trend towards improved outcomes. This has also been shown in the SGLT2, sotagliflozin, in a large-scale trial in patients with diabetes and recent worsening heart failure, improved outcomes. But also the Impulse trial, in which empagliflozin was initiated at time of discharge and showed a host of positive effects, the primary being a win ratio of a composite of endpoints, all favoring, including patient-reported outcomes, all favoring the initiation of the drug at the time of discharge. And finally, I think we've seen now 3 studies that have come in using IV iron infusion in patients with heart failure, showing an improvement in heart failure hospitalization reduction, not so much mortality, but again, adding to our armamentarium of how we can treat patients who've had worsening heart failure. Tremendous excitement, though, of the STRONG HF trial, which built on the GUIDED and said, listen, if you had a protocol where you forced rapid initiation and increase in GDMT, both the class and dose, you can show improved outcomes. And indeed, they were able to show this both by looking at the natriuretic peptide levels, but also their primary endpoint of all-cause death and heart failure and hospital readmissions. And so this has really, I think, taken the field and said our thinking about conventional sequencing is really probably not correct, that we need to be rapid, and the way to do this in a safe manner can be done and should be done. And so just in conclusion, as we wrap up here today, what are the lessons learned from all this data that I presented you? I presented you the whole history of acute decompensated heart failure. You have to know the drug and the underlying pathophysiology. We're still continue to learn that. It's real important to account for regional differences. You saw what happened in the TRUE-HF ularitide trial. Accounting for comorbidities, very important. Renal dysfunction, you saw us try to tackle that. Iron deficiency, a positive effect. Targeting the right patient, you saw that with the natriuretic peptide levels in Victoria and the low EF with omecamtiv. And really appropriately selecting sites and selecting appropriate endpoints, as we've seen here recently with the use of win ratios and composite endpoints. And so I think going forward, we've been involved, and Dr. Rogers has been involved with this, and that is we have to really change the research culture in the United States. Less than 1% of patients with heart failure enrolled in randomized trials. That contrasts to 70% of patients with pediatric cancers. And so how do we integrate that into our clinical practices is really the charge of the Heart Failure Collaboratory. It's one of the main charges of the collaboratory to really improve the ecosystem, to get better buy-in by investigators, patients, and all the stakeholders to improve the therapeutic development. And this working group has been going on now for 5 years. Its most recent publication is just putting standard definitions and standard endpoints out there for how we develop therapies for acute decompensated heart failure. But it's exciting, and my journey will be coming to an end soon. So really, what's most important, I think, is mentoring and building the next generation of investigators and clinicians who are committed to generating new evidence. I've really enjoyed working with many of my mentors, Dr. Rogers included. And I think as we look to the final remarks of what I like to say is that when you think about your career and what you can do, all you can do is leave the place a little better than you received it. And that's what I would consider success. And this is an example here. My good friend David Cutcliffe, who was the head coach of Duke football, did that. And this was one of the highlights when he went into South Bend, Indiana, and Duke beat Notre Dame in football. But thank you again. And I'm so sorry I couldn't be there with you today. And thank you, Dr. Rogers, for being a terrific colleague and a friend. I look forward to seeing you soon.